Next presenter is Anthony Zipple. He's currently the president and CEO of 7 County Services, which is in the greater Louisville, Kentucky area. Tony has more than 30 years experience as a clinical manager, public administrator, consultant, teacher, researcher, and executive in the mental health field. So he brings many different perspectives to the topic at hand. So please join me in welcoming Anthony Zipple.
Well, and it's great to be here, and I will tell you it's a little intimidating following Monica. She is just an icon in the field, and having to follow her on stage is a little bit of a challenge. I wanted to start by telling you a story. Before I fell in love with an opportunity to work with people who had the most severe mental illnesses, I was an aspiring urban planner, complete with a master's degree from the School of Architecture. And I can't remember very much of what I learned in those days, but one thing that stuck with me is the lesson I learned from studying Robert Moses. Now, Robert Moses was maybe the most influential urban planner of the last 100 years. And as any New Yorker here will tell you, he's the person who really shaped the face of modern New York City. He built just enormous numbers of things. He built the Triborough Bridge and the Northern State Parkway and the Southern State Parkway, the Wantagh State Parkway, the Taconic State Parkway, the Brooklyn Battery Tunnel, the Throgs Neck Bridge, the Bronx Whitestone Bridge, the Henry Hudson Bridge, the Verrazano Narrows Bridge. He was responsible for the Brooklyn-Queens Expressway, the Staten Island Expressway, the Cross Bronx Expressway, the Laurelton Parkway. I mean, the list really goes on. An astonishing legacy that he really built for us. He changed shorelines, he built bridges and tunnels, and he changed the face of what we think of now as the New York City region. Now, what was his goal in doing all of this building? Well, he wanted to remake New York City into an auto-friendly region. He had a vision of people zipping down his beautiful parkways and in cars going to the park and going to work and going to shops. He was not a big fan of public transportation at all. And it was rumored, in fact, that some of his parkways, he built the overpasses intentionally so low that buses couldn't get down them. And he couldn't get public transportation on them, and poor people couldn't go to the beautiful beaches and bathhouses that he built along the way. He promoted suburban living on Long Island and urban sprawl. He built special places for retail and special places for play and special places for work, and all of it, every bit of it, connected by roads and bridges and tunnels and automobiles. And when he faced huge numbers of cars that were crowding and clogging up his roads and his bridges and his tunnels, he thought that the solution to it was easy: build bigger roads and bridges and tunnels. It was an immense, immense, grand vision. And it only had one small problem, and that was that it didn't work. The problem that he had with his strategy of building more roads was, like this slide, if you build it, they will come. And they came, and they came, and they came, and millions of people and millions of cars crowded their way into the New York City system, making the city just a driver's nightmare. And traffic in New York actually got worse faster than Robert Moses could spend the millions of dollars of taxpayer money to build more roads and bridges and tunnels. What Robert Moses failed to recognize in this is that when you make it really easy for people to go someplace, they're going to tend to go there until it stops being easy. And the more bridges and roads and tunnels he built, the more people came to New York City, and the traffic stayed really bad. And in the end, he failed not only with his goal of making New York a place that was auto-friendly and where people could get around quickly and easily, he actually diminished the quality of life in New York City in the long term with this strategy. As we all know today, building more roads and getting more cars and people driving in just increases all kinds of side effects. It steals green space for parking. It increases pollution and global warming. It increases commuter time and all kinds of road maintenance costs and other unanticipated side effects. And eventually New Yorkers learned that they couldn't build their way out of it. They needed to reframe the problem, and they reframed it not as a problem with too few lanes, but as a problem with not enough great public transportation. And they did a great job with public transportation in New York City. Today, with the help of a world-class public transportation system, commuters in New York actually spend less time stuck in traffic than commuters in San Francisco, LA, Houston, Washington, Tampa, Dallas, Orlando. I mean, that's really amazing for a city with the density and the opportunity of New York City. So it may be a hard reality, but there are just some problems that you cannot build your way out of. And in fact, the more you try to build your way out of it, the worse it becomes. Let's think about a different problem, a similar problem, prisons. Okay? We know that you can't solve crime in the United States by building more prisons. Adding more prison beds and locking more people up creates a debilitating spiral of creating more stigmatized people, more disenfranchised people, who are more likely to commit crimes and more likely to get locked up, requiring more prison beds. You know, it's a spiral that doesn't work very well. What you end up with is a lot of expensive real estate, a lot of expensive operations, and you still have crime. How about this one? We all know that we've got a growing energy problem in the United States. We consume 25% of the world's oil, mostly on trucks and cars that Robert Moses wanted to get into New York City. We know that we depend on foreign sources for a lot of that, foreign sources that are not terribly reliable, and we know that $4 to $5 a gallon gasoline is really bad for our economy. So good energy policy is a big deal for us. But how many of you believe that the solution to our energy problem is drill, baby, drill? How many of you really think we could drill our way to $2 a gallon gasoline? And of course we couldn't. If we drilled and we drilled and we drilled and we had all kinds of oil and we thought it was going to be cheap, we would just get bigger cars and we would drive more and we would sell more of it overseas and price would stay exactly where it is, but we'd have a lot more oil derricks to show for it. Now, all of these problems share a common basic confusion. They try to fix shortages by increasing supply rather than managing demand. And for these kinds of problems, that never works. For these kinds of problems, easy supply just increases demand, and you can't build your way out of these kinds of problems. In fact, building more usually amplifies the problem, and it makes the situation worse for you. What these situations need is a radical shift of frame from a doomed effort to try to continually increase supply to a smart effort to manage demand. Now, I want to talk for a minute about a problem that we face in our own industry here that's a lot like this. And that's the problem with too few psychiatric inpatient beds in some communities. We know that it's a crisis in some communities in the United States. Individuals with acute psychiatric needs are decompensating. You know, the emergency rooms are full. There are no psychiatric inpatient beds anywhere. It's a real mess in some places. This talk grew out of an interchange on the National Council listserv about this crisis and whether we could fix this crisis by building more hospital beds. The theme for it seemed to be, you know, if only we had more beds, it would fix the access problems and we could fix the current crisis. Now, when I hear that strategy, it makes me really nervous because it sounds suspiciously like a Robert Moses strategy of trying to fix traffic problems by building more roads and bridges and tunnels, or a law and order strategy of trying to fix crime by building more prisons, or a Sarah Palin strategy of drill, baby, drill as a strategy for fixing our energy problems. Building hospitals like building roads is really enticing. It's direct, it's clear, everyone understands it, and it's only got one small problem. It doesn't work. Some of you may remember that in 1955, we had 550,000 state hospital beds in the United States, and they were still all full, and there was still no room for anybody. I'm old enough to remember that when hospitalization used to be a really bad thing. You know, it was expensive, and it still is. It was disruptive to a person's life. It was stigmatizing. We recognized that it really didn't have much long-term clinical value for anyone. We used to believe in this association that it was our mission to make that kind of an intervention obsolete. Now, while I understand that there are some circumstances where a hospital is exactly the right thing to do, you know, somebody's got an acute medical problem and an acute psychiatric problem, or there's forensic involvement, something like that. And there are cases where you may need a hospital, but in general, hospitalization is not a good thing for people. Every time that we send somebody to a hospital, it is an example of our failure. It's a system failure. It's a failure on our part to mobilize better clinical interventions to prevent hospitalization. It's a failure on our part to offer better service alternatives to hospitalization. It's a failure, frankly, on the part of all of us to do the best that we can for the clients that we're supposed to be serving. So what I think we need to do is to figure out a way to look beyond the crowded ER and look beyond the crowded hospital and ask the question, why is it so crowded? Why is it that there's so much demand for inpatient services that we don't have any beds available, and can we really fix that by increasing supply of beds? I mean, here's the real tragedy. We know a lot about how to fix this problem. We know the data on assertive community treatment. We know the data on hospital diversion. We know the data on peer support and peer interventions and intensive case management. We know that the solution to this is and always has been great community services, not more hospital beds. The solution has always been that simple for us. But in spite of knowing that, in many locations, we're pursuing completely the opposite strategy. We're building more inpatient services while we're stripping money out of the community system. For the first time since the Community Mental Health Centers Act in 1963, we are actually shrinking state spending on community mental health services. NAMI reports that since 2009, we've clipped $1.6 billion out of state spending on mental health services. And we all know the challenges we face with managed care, where increasingly we have managed care companies who aren't very creative about services and make it hard to provide peer services, make it hard to do clubhouses, to do the non-traditional things that we know shorten and eliminate hospitalization for people. This is really our failure to build a system that meets our clients' needs, one that really works and eliminates the need for inpatient services. And we should know better. We should know better. We knew better in the 1970s when we were committed to making hospitals archaic and obsolete interventions. When I was an urban planner, I had a professor that used to use what's almost a cliche, that every system is perfectly well designed to get exactly the results that it gets. And that's true. If you want to get different results, you need to change the system. And in this case, if we want to solve the problem of inpatient beds, we need to change the system. Just the way we changed the system in New York City to fix traffic problems. We need to change the system here and build community services, not double down on what's a doomed and frankly cruel strategy of building more hospital beds when we don't need to do them. We need to focus in this association on getting back to our roots and continuing to make hospitalization a largely archaic and obsolete intervention. We need to treat hospitalization as a system failure, as something that's not acceptable, as something that we need to reduce and not expand. Every person who goes into the hospital is proof that we need better and more community services, not proof that we need more hospital beds. And you're in a conversation with colleagues at home about how crowded the ER is and the hospital is, and they try to tell you what we really need to do is open more hospital beds. I want you to think about it for a minute. Maybe you can talk to them about New York City and traffic and Robert Moses. And maybe you can tell them that we learned back in those days that you can't fix a supply problem that way. You've got to figure out how to deal with the demand. Tell them that we know that we don't fix our mental health system by building more inpatient services, but we do it by building a bigger, more accessible, more effective, less expensive, more humane base of great community services. Drill, baby, drill is a terrible energy policy when it comes to how do we find oil, and build, baby, build is not going to solve this problem in the mental health system. We really should know better, and we really should act like it.